So you have joined
Okay.
North Kansas City Hospital's sponsored talk today from the Total Weight Loss Center. And I am just going to let the expert in this introduce himself and take it away from here.
Sounds good. So thank you guys for joining us over lunch. My name is Josh Moreau. I'm one of the bariatric surgeons at the Total Weight Loss Center here at North Kansas City Hospital and Meritas Health. And the idea today, one of the dietitians will be here in a little bit as well. But the idea is to really hopefully be informative and kind of go through some of what we offer. We are kind of a total weight loss center, meaning that we have surgical and non-surgical options. I'm a surgeon, obviously, so the talk today is going to focus more on the surgical aspect of the different treatments that we offer. But definitely can ask questions about anything that you have questions about. So I'm going to try to go through this efficiently so we can get to any questions that folks have. But at the end, there will be time to ask questions either by text or messaging or just verbally. So forgive me if it's not completely smooth transitioning. I have a couple of videos I wanted to show, so hopefully those work out. So I'm going to pull up the PowerPoint here. Let's make sure this all works. And so the talk today is really focusing on the different tools that we have for weight loss. And we're going to, again, spend most of the time on surgery, but there are many different aspects of the treatment of obesity and the different kind of avenues that we can take to ultimately get control of this disease. I think it's important for any discussion of obesity to know what we're talking about. And so obesity is defined, and hopefully everyone can see my presentation here, but obesity is defined by BMI. And so it's a simple calculation.
Wait,
we can do that.
Your screen share is not up right now. I think we took it down to start real quick.
Okay, hold on one second. Let me pull here. And here we go. Sorry about that. So now, how's that? Is that better?
Perfect. Go ahead and launch that slideshow.
All right, perfect. So as I was saying, we need to understand kind of a couple of definitions before we get into discussing the different treatments that exist. So obesity is defined by BMI, or body mass index. It's a pretty simple calculation. And like I was saying, if anybody doesn't know how to calculate that, you can use Google or you can call us. It's a pretty simple thing. You just need to know your weight and your height, and that will determine your BMI. The reason that we have a box around BMI higher than 35 is because that's typically where insurance companies will start to cover surgical procedures. Now we're seeing that actually change a little bit, and there are some insurance plans that are starting to talk about situations where coverage may extend down to where obesity actually starts, which is down at a BMI of 30. But it's important to understand that BMI is going to be a part of the discussion because it helps us define your weight loss with surgery and some of the other comorbidities or other medical issues. So let's talk a little bit about the problem. This is 1985, looking at obesity across the United States. And you can see, and I promise this won't be too detail oriented as far as looking at all these different graphs, but you can see that in 1985, no state had more than 15% of their population in the obese category. And as we kind of progress through 87, 89, you kind of see the epidemic emerging, and you see obesity becoming a bigger and bigger problem. Here we are in 1999. You start having to add a new category. You've got now up to 20% in states that are even over 20% of their population in that obese category. Again, a BMI over 30. And so we go forward, that's 20 plus years ago. We go forward to, let's go to 10 years ago, so 2012. The picture's a little different, the colors have changed, but the scary thing is now in the legend there, we have new categories. We've got a number of states now that are, a third of their population is in this obese category. And they've started to anticipate already in 2012 that we're going to have states that are even higher than that. And so the end of the story as far as this goes right now is that we jumped 35 years from 1985 till now, and we see this explosion of obesity, this emerging epidemic. And so whereas in the first picture there, no more than 14% in any state, now you don't have any state that's less than 20%. Colorado's, Massachusetts and DC are the only places that have even in the 20 to 25% category. In the South there, you can see multiple states that are getting into the close to 40% obesity. So this is a disease. It's a real problem. It's not something that, people just don't try hard enough, or all of these kind of false narratives that get put into society about what obesity is. It is a disease, and it has real consequences. If we look at its effects on kind of our society in the United States, in 2018, 42% of the US was obese. That number continues to go up. We kind of showed this in graphic, but obesity doubled from 1980 to 2008. Now, we're not talking about childhood obesity today, but it is a huge problem as well. We're seeing diseases that are supposed to be adult diseases crop up in children because they're driven by obesity. And then you look at the healthcare costs, and they're becoming astronomical. $344 billion in 2018. If you break that down, going back to 2010, over $1,500 per person if you are in the obese category. So you're spending $1,500 per year more per person because of obesity. Kind of scary numbers here. If your BMI is over 40, the CDC, this is a study in the Lancet, which is a pretty well regarded journal. If your BMI is over 40, you're losing 8 to 10 years of life expectancy on average. So all of this is pointing to obesity as a problem. We show this picture often at seminars for surgery, and it really highlights why a lot of people are looking to weight loss surgery. For sure, people want to lose weight, but a lot of times they want to deal with multiple of these problems: diabetes, heartburn, heart disease, polycystic ovarian syndrome, joint pain, all these different problems that we know are linked to obesity. Within the cancer category, every year we find that more and more malignancies or cancers are directly related to obesity. And the really neat thing about a lot of these problems is when we fix the obesity, we fix all these other medical issues as well. So why is this happening? It's not difficult to imagine that it's multifactorial. It's caused somewhat by our genetics. We're born with certain predispositions, but then we're also affected by the environment that we're in and certain behaviors that we may develop either because of that environment or for other reasons. So 20 years ago, you got a cup of coffee, it was 45 calories, 8 ounces, and you were done. Now you go and get your first mocha of the day, and you're 350 calories in. So we have, completely different habits now that we're really loading our body with high calorie intake that then drives obesity. Food choices obviously don't help in a lot of situations. We're a busy society. We tend to eat a lot of processed foods, a lot of pre-made foods that are low in fiber and high in fats and carbohydrates. And, again, don't help the issue. And then very rarely do we find time for exercise. Everybody drives everywhere. Everybody's busy. It's hard to find time to walk as much as maybe generations before us did. And so there's multiple options. Like I said, we're the Total Weight Loss Center. So I'm one of the surgeons here. We have another surgeon as well, Dr. Berghoff, and then we also have a bariatrician, Dr. Brianne Kelly. So we offer multiple options for weight loss. This is an example of a couple of the different medications that are used to treat obesity. But today we're going to talk a little bit about surgery. So multiple studies have shown that when your BMI gets over 30, excuse me, the effectiveness of non-surgical, so medical-driven weight loss is pretty poor. And that's not to say that it's not worth trying. It's not to say that folks that do medical weight loss are, doomed to failure. It's just that this is a real disease, and we know that where we sit in 2022, often the best treatment is surgery. Hopefully we get to a point in the future where we're even more effective with medication than we are now. But the thing we know right now is that surgery tends to be the more durable, the more long-lasting treatment. So this is kind of one of those slides that highlights the idea that we're really attacking multiple diseases by treating obesity. So look at these different conditions that are very often related to obesity: type 2 diabetes, hypertension, sleep apnea, dyslipidemia, which is high cholesterol type issues, and cardiovascular or heart disease. Overall, we see significant reduction. So this is not most, this is nearly all. 92% of type 2 diabetics that are obese, 75% of hypertensive patients, 96% of patients with obstructive sleep apnea. And so these are showing that not do these diseases get better, not do they improve, they are in complete remission. So they're not requiring medication anymore. And these are definitely some of the big reasons that we see folks come and see us in the clinic, is because they've dealt with diabetes their whole life. It's affecting everything. They know that if they don't do something soon, that it's going to start limiting, or already has limited, their ability to live kind of the life that they want to live. And so when we look at obesity as a disease, which the medical community has now for some time, there are a couple of really powerful statements that have come out of organizations that are not surgeons. So the American Heart Association in 2011 said that bariatric surgery can result in significant reduction in cardiac and other risk factors. The American Association of Clinical Endocrinologists, again, so folks that are dealing with diabetes on a very extreme scale, said that there is significant clinical evidence to declare obesity as a disease state. So again, it's overturning that falsehood that obesity is equal to laziness or equal to not trying hard enough. It's absolutely not that. It is a real disease. And these societies back in 2011 started to really identify bariatric surgery as one of the real, or one of the only ways to really treat these diseases. And then this was a big deal back in 2018 when two of the major organizations that deal with guidelines for treating diabetes, the American Diabetes Association and the European Association for the Study of Diabetes, came out and said that if your BMI is over 35 and you have type 2 diabetes, that the recommendation is surgery. It's a huge statement coming from, again, two groups that are not surgeons. These are medical doctors that have treated diabetes for a long time with medications and surgery, but they're recognizing that the results of surgery are so dramatic that it rose to the top of the primary recommendation when patients qualify with a BMI over 35 and type 2 diabetes. So very powerful statements. So now kind of more the technical side of things. There are a couple of different procedures that exist for weight loss surgery. This is definitely not an exhaustive list. This is the list of surgeries that we think at the Total Weight Loss Center are effective operations and should be performed. There are other procedures such as the lap band and a couple of other variations of the procedures we're going to talk about that you'll hear about. We can definitely talk about those, but these are the three that I think are, that we think are effective. So there's the laparoscopic sleeve gastrectomy, the laparoscopic Roux-en-Y gastric bypass, and an operation called the laparoscopic biliopancreatic diversion with duodenal switch. It's also called a duodenal switch. And there's actually some variations on that procedure as well. But I wanted to go through just to give folks an idea of what these different procedures look like. So this is where I'm going to try to use video. It may or may not work. So if it doesn't, I will go ahead and I do have some just still pictures that we can look at. So to orient everyone, this is what the inside of your body in diagrammatic form looks like. So if somebody's looking at you, that's why I put the right and left there. It's flipped. So, and I can't really, well, can you see my mouse or no?
Yes.
Okay. So again, right side and left side, and then we'll throw some labels up here. So these are common structures that people, I think, know the name of. They may not know where they are, so this is helpful. So when you eat, food goes into your stomach, and then bile from your liver that may be stored in your gallbladder meets your food, and you kind of start to digest. And it goes through your small intestine. We also call that your small bowel. Everybody has about 20 to 25 feet of small bowel, so we all have a lot of small intestine. That really helps us to absorb all the nutrients and calories that we need to absorb from food. And then from your small intestine, it goes to your colon or your large intestine or your large bowel. Those are all the same thing. It passes your appendix, which doesn't do a whole lot for you, and then goes through your colon, and ultimately that's how we have bowel movements. So this process is what we're looking at when we talk about the surgical treatment of obesity. And we can affect it a couple of ways. In all of these, we're going to reduce the size of the stomach that your food sees. And in some of these, we're also going to affect the absorptive capability of your small intestine by adjusting kind of how much length of small intestine your food gets to see. So in a sleeve gastrectomy, let's see how this goes. So in a sleeve gastrectomy, there we go. In a sleeve gastrectomy, you start with that stomach, and we're going to remove about 80% of the stomach, and that goes away forever. So now you're left with this tube, and it's, like I said, it's about 20% of your original stomach size. And so after sleeve gastrectomy, we have a significant reduction in your stomach, so you feel full quicker. You eat, and that smaller stomach fills up faster, and you feel full. There's also a reduction in a number of hormones that are called hunger hormones as a group. They do have specific names, but there's a number of hormones that are secreted by the part of the stomach that's removed that are subsequently decreased after the surgery. That is not a permanent change. We do see those hormones start to come back up over time, but there is a significant reduction in the sensation of hunger after this operation. We expect patients that have this operation to lose about 50% of their excess weight. So if you're about 100 pounds overweight, as an example, excuse me, to make the math easy, we would expect you to lose about 50 pounds. So 50% of excess weight. This is by far, among these three operations, this is the lowest amount of weight loss, but it is a very common procedure that's performed. The next one is the Roux-en-Y gastric bypass. So starting with the same stomach and small intestine, let's see if this works. I'm going to make a small pouch that ends up being about the size of an egg, and then go down about 4 to 5 feet on the small intestine and divide the intestine or cut it and bring it up and connect it to that pouch. So now when you eat, food goes into that pouch. You feel full quickly, which is very similar to the sleeve gastrectomy, but now you have the second component where you absorb fewer calories from the food that you just ate. And so by having this dual effect, we see an increase in weight loss up to 80 to even 85% in some studies. So again, that same person that's 100 pounds overweight, instead of 50 pounds with the sleeve, we would expect more like 80 to 85 pounds with the gastric bypass. And finally, the duodenal switch, and we're showing a version of the duodenal switch here called the single anastomosis duodenal ileostomy, which is a version of the duodenal switch. This one's a little bit more technically involved, but it is essentially the same two components like a bypass. We're going to perform a sleeve gastrectomy, the same sleeve that we talked about with the sleeve, and then also perform a bypass below the sleeve. And so in doing that, we now have that same effect where, let me see if I can get this down, where you fill full quickly from the sleeve and then absorb fewer calories because of that bypass portion. This is a larger bypass portion of small intestine. And historically, this has been an operation that's reserved more for folks that are in the BMI category that gets up into 45, 50, and higher. This is the highest weight loss procedure that we do, with weight loss sometimes in excess of 90%. So again, all of these procedures are effective for weight loss. The sleeve gastrectomy is going to be on the lower end of weight loss, but in certain patients, it is a good procedure for various reasons. Then the gastric bypass and the duodenal switch are going to have weight loss more in the 85 to 90% range. And we pick between these procedures based on a number of factors that I think is not something we'll go into now unless people have specific questions. But the great thing about having different options is similar to medication. We don't just, when you come and see us at the Total Weight Loss Center, we don't say, hey, we do this one thing and this is the one thing we offer and this is what you're getting. We don't do that at all. We say, you know, what are your medical issues? What are the different surgical procedures you may have had done? What are your weight goals? You know, what are your environmental factors before we make a decision about what the best operation for you is. In all of these, we talked about laparoscopic. That means small incisions. So the picture on the left is kind of classic abdominal surgery with a big incision down the middle. We want to avoid that, particularly in obesity, because the rate of hernia formation in obesity is very high. So these operations are all done with somewhere between 4 and 6 small incisions that are about the width of your pinky. So we can do through these small incisions the exact same thing we would have done through a big incision, and we avoid the concern about infection and hernia that comes with a big incision. We use all kinds of cool instruments. We do these laparoscopically. This is also an example of a robot. Our clinic, we do these operations both ways. All of the operations we do either laparoscopically or robotically from start to finish. The point of these technologies, the pictures are cool, but the point is that it helps us be more efficient, and it helps us keep people in the hospital for shorter periods of time and get folks through to what they actually want to do, which is continue living life and losing weight and feeling better. So the key things, hopefully that you got out of this is that, number one, obesity is not laziness. It's a disease. It's a real disease that affects lots of systems in our body, and we have to treat it like a disease in order to successfully control and treat obesity. You know, we saw all the different comorbidities and how they improve after we treat obesity. We talked about the different options, and also talked about the fact that right now in 2022, surgery is the ideal option for long-term success, particularly as our high BMI, or as our BMI gets higher. And the last thing that we always tell folks is it's not one size fits all. You know, sleeve may be best for one patient, gastric bypass may be best for another, duodenal switch may be best for another, and somebody else may do medical weight loss. So we're by no means saying do this particular treatment. We're just saying, if you have concerns about obesity, if you're worried about the effects that it's having on your life, to come see us and we can come up with a plan. So I'll leave this up. You can scan that QR code and it'll point you to the Berrytastic app. It has kind of our information in there, and it's also a great app for tracking. We have Facebook and Instagram accounts that you can follow as well. And with that, I think that's all I have. So I'll pull this, and I can actually leave this up for a second. Jackie, one of our dietitians, is also here. So I think I'll just open it up if there are any questions. I appreciate y'all's time again. I know it's busy in the middle of the day, so thank you guys very much.
All right, thank you, Dr. Marrow. That was very, very informative. There was a lot of information in there. I think I'm probably going to have to watch that a couple of more times just to make sure I got it all. So
yeah, it's definitely, there's kind of a lot to digest. I think it's helpful to recognize, I think the big thing is it's a problem that's complex, and there's a lot of different options to try to attack it.
Yes. Okay, go ahead and stop your screen share for me for just a minute so we can see you and your full face. There we go.
Okay.
Okay.
Oh, you want to just, I got you.
So if you guys have any questions, you can enter that in the chat or the Q&A. And I haven't seen any pop up yet. I am sure that as people go back through and consider what you have talked about, that there will be plenty of questions. So if you guys come up with any questions after you've kind of looked through your notes and maybe watched it again, please feel free to reach out and ask those questions so that we can absolutely get them taken care of, okay? And this is going to be, it has been recorded. I'm sure you were notified of that at the beginning of the webinar. And this will be placed on YouTube, and I will be sending out a link for everyone to watch as soon as it is up on YouTube. So, oh, we do have one quick question. Can you give a quick overview of non-surgical options?
Sure. Yeah, and I can actually have Jackie here as one of our dietitians, and she can talk a little bit about that. I'm going to let her slide into this chair. And again, I appreciate everybody's time, and we will definitely, if people have questions, send them to us, and we can go through and we'll get those answered. But I'll let Jackie jump in and go over that for you guys.
Thank you, Dr. Maria. All right. Hi, guys. Medical weight loss. That is a great question. So medical weight loss, the 4 pillars of that are going to be medication, exercise, nutrition, and behavior. So I can't speak to all clinics throughout Kansas City, but in our clinic, what it looks like is that you set up a meeting with our clinic bariatrician. You go over health history. She will talk to you about medications that may be weight positive, and ones that maybe are weight negative. She will talk to you about options for switching some of those weight positive medications to more weight negative. And then she will go through all the different weight loss medication options with you, and if it's a good fit given your medical history. I know Dr. Moreau mentioned a couple of those that are out there, but the market for them and the research going into medications is increasing dramatically. And Dr. Kelly is a wealth of information that will really walk you through step by step the different options and which will be the best fit for you. As part of the medical weight loss program, you'll also meet with our clinic dietitians. We have nurse practitioners, and then we are partnered with the fitness center as well to incorporate that exercise component as well. So that's kind of an overview of what the medical weight loss side does look like.
Yes. And Jackie, while you were talking, I went in and I found where Dr. Kelly had done a talk. She had actually done a lunch and learn back in April. So she covered that what medical weight loss is non-surgical pretty extensively, and that is on YouTube. So I will go ahead. That's a really good topic to just overview again. And I will put a link for that YouTube video in with the surgical options for weight loss as well whenever I send it out.
Perfect. Yeah. And if you want to also, Shanna, if you could put my email, if anybody has other questions, you are more than happy to email me. My office is right next to Dr. Moreau's, so I'm more than happy to, if you think of any questions down the road, I'm happy to chat with him and get those answers to you.
All right. Perfect. I don't see any more
Let's see.
questions, Jackie. Okay, guys. Well, you heard that. So if you have any questions, check for my email, and Jackie's contact information will be in there as well. So you can ask them later
Yeah.
too.
Perfect. Well, thanks for joining us, everybody. We hope you have a good rest of your day.
All right. Thank you. Bye.
Bye.